the journey that's in front of this area of research and patients in need is a very exciting one, because the journey has almost happened already in heart failure. Traditional heart failure, if you want to call it that popularly. But so that happened the last 30 years, going from one single or maybe double therapy, mostly pump-related questions, fluid and pump capacity of the heart, and to be much more holistic in its approach and dealing with hormones, etc. Balancing the efforts of the different medicines to optimize care. With fantastic results. And PAH is behind that field. I think the lung cardiovascular field is behind. So there is much to do. And actually the efforts will be moving from pump-related hemodynamic questions, which are important to improve, but to the more underlying causes of the disease. Why do these patients develop the disease, and what can you actually do about the underlying causes? And here I think there are already movements towards new therapeutic agents that might do reverse remodeling, which we call it, in these patients, pulmonary artery and right ventricle of the heart, which develops hypertrophy, stiffness, and a bigger heart, which eventually fails pumping against a higher pressure in the pulmonary system. And we have indications from our preclinical studies that our drug looks very interesting and has reverse remodeling capacity, both the vessels and the heart. And of course, now looking at the data that we have seen a little of from our phase 2 study, it indicates that possibility based on the information we have of clinical improvement. But it's, again, early days. The reason we believe that our drug will have this capacity even in man is that the pathophysiology of these patients behind the disease is very well connected and like a hand in a glove, basically, related to those characteristics that we have with the drug and which has been proven in animal work. So anti-inflammatory, anti-fibrotic, anti-thrombotic capacity, causing reverse remodeling, and also is both systemic and pulmonary pressure reduction. So this is a very nice, complex, signal disrupting drug or mode of action that HDAC inhibition has, which we have with VPA in our CS1 drug. This is also the reason why we're developing a new HDAC inhibitor in CS014, and we'll bring that into clinic if we keep our plans before the summer. So we believe that HDAC inhibition will have the capacity not only to impact structural development in various cardiovascular indications, orphan or common. So the structural element of cardiovascular disease is important, fibrosis and hypertrophic development in vessels and heart, which are leading then to consequences and including higher pressure and then eventually myocardial infarction caused by thrombosis or stroke, which is thrombosis or occlusion of vessels in the brain. And HDAC inhibition with both CS1 and CS014 has been documented in our preclinical work to prevent thrombosis without causing risk of bleed, which is the key element that you'd like to improve in thrombosis prevention in man. 3 out of 100 patients on current drugs die of the therapies because they cause an increased risk of bleed 24/7. So we might have an agent here that not only can impact structural changes, but can also prevent the end dilemma, which is thrombotic events, without causing increased bleed. So that's the next drug, CSO14, with HDAC inhibitor capacity. So yeah, we think we are on an exciting track.